All right. Good morning, good afternoon, good evening to all our colleagues that are logging in from remote and across the oceans here. Just want to welcome you back to another exciting session of the Australasian Plural Seminars. Today, we're very fortunate to have our very own star pathologist Celia Green joining us to talk to us about plural cytology and cytology for pathology for beginners. For those that were here for our plural summit yesterday, we got to hear her speak then and give us her insights and really educate us quite a bit about what goes into giving good samples, and so we can help them help us kind of thing. So remember, we do record these so they're available if you've missed them or missed the first half if you're logging in a little bit later. But without further ado, I introduce Dr. Celia Green here, one of our star pathologists, that without her, we really couldn't do anything that we do. So I'll pass it on over to her and get her started.
Okay, hi everyone. Thanks for having me. Sorry for those of you who saw me yesterday and have to see me again. Hopefully you can see my presentation. So this is a beginning slide. Dhaval, can you just confirm that you can see me?
We can, yep, go for it.
All right, so today we're going to go through basics of pleural histology, learn a little bit of lingo. We're going to talk about patterns rather than diagnoses, a little bit about mesothelioma, we must, and why is it so hard, and then a little bit about keeping your pathologist honest and trying to get what you really need out of pathology. So the first thing is junk in, junk out. And pathologists can be very Oscar the Grouch about this sort of stuff. So you guys really need to provide something for us. Patient risk factors, infections, exposures, do they smoke? What geography are we dealing with? Clinical presentation and course, we do use it. Pain, breathlessness, etc. The imaging findings, we're lucky enough that we usually have access to the imaging, but your pathologist, depending on where you are, might not have access to the imaging provider, so providing details about what you're seeing is important. Any thickening, effusions, lung lesions, particularly any history of other cancers, relevant clinical details, fever, history of cancer. If they're dying currently, super relevant. They can try and move faster for you. And finally, really importantly, a question. What do you need? We need to try and answer for you exactly what you want. So normal pleural histology, I've actually borrowed this photo because we don't get a lot of normal, but essentially a normal setting, you get a very thin fibrous layer, which is the pink stuff in the middle here. And there's often an inconspicuous or sometimes invisible mesothelial layer, which are just cuboidal cells. And at the edge, there's often adventitial fat. And in the biopsy, you'll often get skeletal muscle adjacent, as along with some vessels, which are usually bigger than those ones. And cytology in the normal setting, it's quite cellular. It's an exfoliative fluid from a source, and so you'll often get many macrophages, a few little mesothelial cells or clusters of mesothelial cells, and a few lymphocytes. Different inflammatory cell patterns can happen. You can, even in the normal setting, get a couple of neutrophils and rarely eosinophils. And if there's a reactive process going on, whether in connective tissue, infection, etc., mesothelial cells can actually be quite plentiful in normal reactive fluids. So I want to talk about the patterns of injury that you're going to see, what you should consider, and why they're patterns rather than diagnoses. So the most common one you're going to hear is a fibrinous pleuritis, and I always have arguments with Gary about whether this is a diagnosis or not, because essentially this is the most common reaction pattern that we're going to see. And there are a million causes. It's a little bit like ARDS, you can list almost anything that can cause a fibrinous pleuritis, but trauma, infection, you can get it adjacent to tumor, connective tissue disease, autoimmune diseases, or even drug reactions. And this will be the pleural surface over here. And this is all fibrin or sort of clotted material. And this adheres to the fibrinous surface or fibrous surface of the pleura. And then this gets expanded and you get this inflammatory infiltrate. And you can see just how thickened this pleura is compared to the previous example. So on imaging, you'll be seeing quite a thickened appearance. So when we say a fibrinous pleuritis, because of the many causes, there's not going to be many other clues. If there are other clues, it'll usually fall into a separate category, whether it be granulomatous or etc. So that brings us to what we would see in a granulomatous pleuritis, and this is more low power vision, and then I've got a little bit of a high power in this little box here. So again, you've got a bit of fibrin and inflammatory cells which stick around and sit at the surface. And then this fibrous pleura is much more blue this time because we've got many more inflammatory cells rather than fibrin and blood and junk sitting in there. And then these areas here are zoomed up, and that's a granuloma, which is essentially a collection of epithelioid histiocytes, and that's surrounded by lymphocytes here. So you can get this in GPA or EGPA, sarcoidosis, rheumatoid, infection, particularly mycobacterial or fungal, foreign body, and even some neoplasms have granulomas associated with them, particularly T-cell lymphomas and Hodgkin's lymphoma. So another pattern we see, usually more on cytology than you would get in a biopsy. I don't think I've really seen any eosinophilic biopsies, but there are very many eosinophils sitting together with the macrophage population in here. The most common cause of an eosinophilic pleuritis is actually just a repeated tap, but anything from pneumothorax to pulmonary embolism. And then in the small print, because mostly surgery, repeated tap, or pneumothorax are going to explain the vast majority of eosinophilic effusions, the small print is actually things like asthma, peripheral eosinophilia, or infection. And then finally, neutrophilic or empyema, again, because we don't see so many biopsies of this, because usually radiologically it's pretty common, you just get masses of neutrophils with occasional reactive mesothelial cells. So they're the main patterns that we see, and where you're going to normally give you a category, and then that's why it's so important that you give us information, because if you tell us the person is presented clinically like this with a certain infection history or a smoker, then we narrow down your differential diagnosis. And I'll talk a little bit more about what you can do once you get your differential diagnosis. So mesothelioma is an important nightmare. So why is it so difficult for pathologists? It requires one of the following. So on histology, it requires overt cytological abnormality and mitotic activity. In other words, it has to look malignant. It needs otherwise evidence of invasion. So if you have a bland looking mesothelioma, you can get evidence of invasion through the pleura. You don't necessarily need it to be into the fat or skeletal muscle on its own. Into the pleura itself will be enough. Or you can have a malignant immunophenotype, but you do need one of those categories. And if you're doing it on cytology, you either need, again, the malignant features or a malignant immunophenotype. And the advent of the new immunophenotypes that tell us about malignancy are really important in this space. So what are the problems? So mesothelioma is mostly a bland malignancy. There are cases where it will sort of declare itself and look ugly under the microscope, but most cases are actually quite uniform. And the other problem is the flip, which is that reactive mesothelial cells are cytologically hideous. So I was saying yesterday that the worst mesothelial cells I've actually ever seen were in a patient who had chemoradiotherapy. So they look way worse than even cancer cells. So, you don't want someone to call those things malignant because, a false positive is worse than a false negative even. And then the other problem is that biopsies can be hard to get. You know this better than anyone. And sometimes it won't show the full thickness or invasion depending on the fragmentation of the biopsy. They can also be hard to orient correctly when we get them and embed them, making a cross-section of the pleural surface out to the adventitial layer difficult, so we're not exactly getting a beautiful anatomical conception. And then finally, it's experience. Not all pathologists are experienced in the diagnosis of mesothelioma on tissue or on fluid. So we're going to play the guessing game, 2 cases, which one is mesothelioma, and in both cases you can see that there is a very bland population of spindled cells thickening the fibrous pleura. And this one is actually a desmoplastic mesothelioma, which is subtly infiltrating the fat here, and this is the fibrous area of a reactive fibrinous pleuritis. So when we get the biopsy and we say, look, it looks like a fibrinous pleuritis, but we do have to do some more work and make sure. This is the situation we're seeing, where you've got this organising phase of a fibrinous pleuritis, which can mimic a desmoplastic mesothelioma, and we're just making sure that we're not missing anything. Now, I did this yesterday and I used 2 benign cases, and I've actually changed over the picture today. So we do actually have 1 reactive and 1 malignant case. And this is to show you that when you have a dispersed mesothelioma and or what we call a single cell mesothelioma, they can be really hard to track. So a reactive pattern will look very similar to a mesothelioma. And so this is mesothelioma, but these cells here are the malignant ones, and these cells here are actually benign macrophages. So a lot of these cells you're seeing here are benign. These ones here are malignant, and then all of these are reactive. The other thing is this is slightly closer, so this looks a bit worse, but this is a bit further out. But the problem is for us that without a little bit of evidence from our immunophenotype, these will look very much like each other. So just some other appearances of what we might see, and these are ones that are a little bit easier. So on histology, this is a biphasic mesothelioma, where you've got these glandular formations clearly invading through the fibrous pleura, and this is the spindled component, which is dark, nasty, and forming sort of dark, ugly areas. This is just a glandular or tubular mesothelioma rather, and this is just a reactive stromal response from the fibrous tissue. And this can make it very easy because the stromal response tells you that there's something being incited, because as these move through the fibrous pleura, it's reacting. So, these are the circumstances by which you would look at it and you would immediately say, yep, this is mesothelioma. And this is the cytological examples. So this is a dispersed mesothelial population. This could be benign or it could be malignant, and there's no way of telling until you get your immunophenotype. But this on the right is one of you can look at it low power and be absolutely certain that this is mesothelioma. So you've got really large aggregates of these cells, which is not a normal situation to happen. So if you get this and we can call you and say this is mesothelioma, great. But if you get this one, you're going to get someone who's hedging their bets and then going to need another couple of days. So the advent of these immunohistochemical stains has been very helpful. We've been doing cytology for malignant mesothelioma for 30 years in WA, but this should allow more and more laboratories to come on board cytologically. This is a stain of BAP1. So these are macrophages in the background that have retained the nuclear stain, and the abnormal mesothelial cells have lost nuclear staining. And this is MTAP, which is associated with CTKN2A loss on cytogenetics. And again, you get the loss of staining, but it can be quite patchy and it can be very difficult to interpret. So unless a tumour is present, we see a pattern, not a diagnosis written on the pleura, and the differential diagnosis that we provide will depend on the information given to us clinically. But information could be missing, and or the pathologist might not be experienced, and that can lead to a breakdown in communication and a report that is not very helpful. So you need to keep yourselves and your pathologist honest, and then if you both input that way, then you'll be able to come to quite a tight differential diagnosis, as opposed to saying something like infections, drugs, tumour, because that's not helpful. So pick up the phone, call us. Speaking to someone or your pathologist will tell you a lot, and it won't, not just about the biopsy, it'll tell you about their experience, it'll tell you about their enthusiasm, it'll tell you about their clinical acumen. It's an opportunity. You can refine the differential. If they suggest something, you can say, no, this is not in the differential for us on the basis of this, or cover the things that you couldn't fit on the form or didn't quite sort of translate in writing. Plan the next step. So if you've got your differential and then you've both discussed it and you still feel that it needs to be refined down, what does the pathologist need to get where you need them to be? If you've got a fluid and you've got a lymphocytic effusion and you don't have any abnormal mesothelial cells, but you're convinced this is mesothelioma, what does the next step have to be? Do we need to do a biopsy? Are we worried that this is going to be a sarcomatoid pattern? And then meet your expectations. Patterns are not entities. You might not get to a definitive answer, and the biopsy may not be representative, but you might get a granulomatous pattern and you might get a positive anchor and you might be able to put it together clinically. But if the pathologist doesn't have any of the information about the patient's background or vascular autoantibodies, then they're not going to be able to make that diagnosis. But if someone gives me a relevant blood test and clinical background, I'm just going to bottom line it as EGPA rather than saying the differential includes this, and listing 3 other granulomatous processes. And then finally, just because the needle's in the lesion does not mean the lesion is in the needle. You'll be learning that I do say this all of the time. Taking pictures of your needle in the lesion is not going to convince us that you've actually got it there. So I want to talk a little bit about red flags in reports that you can pick up, that you can hopefully start to chase down your pathologists and get better communication, because smarter interpretation and understanding your pathology is going to lead to you being a more empowered clinician. So non-diagnostic category. This should mean that there's a lesion or area of interest that you've targeted. There's an area of pleural thickening and you've tried to biopsy it, but the biopsy doesn't explain it. So a red flag for you should be if too many cases are called non-diagnostic by your pathologist, or they describe something abnormal and then a non-diagnostic category is given. You need to further look into that. Another situation that is one of the really concerning ones for me, and I see far too much, is a benign category. So a benign should mean that there's an explanation for what's been targeted and it's benign. There are very few things that you can target and then call benign when they're in lesion. But if you have a mass or an abnormal process and they say benign normal pleura, do not walk away. That's a non-diagnostic biopsy, not a benign biopsy. And that's inappropriate use. And then finally, indeterminate. Truly indeterminate should be reserved for cases where there's a process present and we can describe it, say a fibrinous pleuritis, but the differential includes a benign process and a malignant process. So this is like the early phases of, is this desmoplastic meso or is this reactive fibrinous pleuritis? And so that's, but it should not be used as I don't know by the pathologist, because basically they should have a differential that include those things. So if your report says indeterminate and a list of differentials is not provided, you should ask why, and you should ask what are the differentials then? Because if it's indeterminate, you're saying, well, then what is it between? And then the question from there is, why haven't you called it non-diagnostic or benign if this is what you're tossing up between? Because if their differentials all include all benign processes, you can move along. And if you differentials all include malignant processes, then you can start a very different activity. The biggest red flag for me in cytology is no immunohistochemistry. Single cell mesothelioma is common enough. Bland mesothelioma is very, very common, and there's a very high asbestos exposure throughout Australia. All pleural fluid cases should have immunohistochemistry performed in Australia, and if it's not performed, you're going to miss it. And I've seen many single cell mesotheliomas missed because no one did the immunohistochemistry, and it was called negative for malignancy, reactive mesothelial cells. You can't diagnose what you don't look for. The presence of a singly dispersed mesothelioma existing and bland mesothelioma existing means that you cannot think that you know more than you do. And then finally, the forgotten red flag is just one I want to mention. Recurrent lymphocytic effusions. A pathologist should flag it. If I get a second lymphocytic effusion in a patient, or even if it's a first lymphocytic effusion with a suspicious imaging, the next step needs to be telling the clinician to consider a biopsy. A lymphocytic effusion is commonly either masking a single cell bland mesothelioma or a non-shedding sarcomatoid mesothelioma. There need to be special stains done and attempted, and if they're negative, like I said, consider biopsy because you could be dealing with a sarcomatoid mesothelioma. Any questions?
Amazing. Thank you, Celia, so much for your talk. It's always great to hear you talk about this with your passion behind it. So, I will open up the chat to any of our participants. Please type in some questions, anything that you have to ask or share will be welcome. In the meantime, I will start off with a question. It kind of came up a little bit yesterday, but I think it's important for our audience to understand in terms of when to ask for levels to do more. So, I mean, that's the one thing I was taught as a fellow. I didn't know I could do that. One, I
Yep.
didn't know I could call a pathologist, right? So I think that's one thing that you mentioned is really just like you would any of your colleagues in the hospital. It's essentially calling for a referral. If you don't speak with your pathologist, we do it on site all the time in the bronchoscopy suite. But similarly, I think it's so important to have that conversation, build that rapport, build that relationship, so you can really trust each other and work together and share that information freely. So I think that's one thing I would highly, highly advocate for everybody in our audience to do. But to get back to my question a little bit, in terms of when to ask or what to ask in terms of levels or anything else that you would recommend, Celia.
Yep. So we were discussing yesterday that often cell block issues, if you don't have enough material in the cell block, the first pass is usually the best pass. So there are occasions where legitimately the cell block doesn't have anything in it. Mostly, if you have a good biopsy and you've got repeat passes that have been put in for cell block, it's usually a preparation issue if you're not getting a good cell block. So if someone gives you a non-diagnostic sample, or they say that they're limited by something, then have they done levels? So most laboratories will only cut the first level, and then the pathologist will look at that. We automatically look at two, and if before you render a non-diagnostic, I would say probably 12 levels is sort of the minimum in this situation. And a lot of my colleagues at least go to 9 levels. But if you see that no levels have been performed, or it isn't reported because sometimes people are less descriptive in their reports, ask the question. If it was non-diagnostic, or if you've said the cell block is empty and we can't do anything further, were levels done before that was said?
Brilliant. Thank you. And then the other question is kind of what can we do to optimize our specimens or samples in terms of getting them to the pathologist directly and truly we're getting it in your hands as quick as possible, or what other steps that you think we would recommend for us to know?
Yep. So if you don't have a pathology site that you can directly send your fresh tissue within the first sort of 10 to 15 minutes, we do know that tissue does degrade within 10 to 15 minutes of not having formalin. So it depends on your triage. If you are confident that this is lesional and not infection and you've done a lot of things, and you know that you've got a fair distance, putting your biopsies into formalin is not a bad idea. In terms of cytology, it needs to be refrigerated if it's not going to be given directly to the laboratory. Ideally, less than 48 hours in the fridge at 4 degrees. Putting it in a clean and hopefully sterile jar is obviously the most important thing. You do have special collection jars that will contain EDTA and other things to lyse blood and help them go along. But yeah, with particularly your tissue biopsies, if you can't get them to within your central lab within sort of 15, 20 minutes, consider separating your microbiology sample yourself and sending that and putting your tissue biopsy into formalin.
Brilliant, thank you. And something along kind of like that time sensitivity as well. I remember as starting off at the VA in my first consultant job, there was a few times where samples kind of just sat around for a little bit. And I had asked for a cell count differential, and they said, "Well, it's been sitting around. We're not going to be able to give you this." Are there any other specific things that you would say are going to be quite time sensitive and that we should be aware of, especially if we forget to order it and want to add it on or anything like that?
Yep. So if you've added fixative, you won't be able to do microbiology afterwards. So you need to separate that first. Flow cytometry also cannot be done on fixed tissue. Flow cytometry have its own RPMI, which you can put in to keep it lasting longer, but it needs to be within that in the first 24 hours. After 24 hours, you're going to have too much degradation of cell material for it to be performed with flow cytometry. Once tissue is fixed, you can do anything indefinitely. With a cell count, within 24 hours or 48 hours, all cytology specimens should still be able to have a cell count performed. That might take a little bit longer. It's not going to happen because a scientist is going to have to do that. But yeah, it should be able to be done on any specimen that's within 48 hours.
Okay. And then, you mentioned, fancier testing, BAP1 and MTAP and things like that. So, I mean, I don't know that all labs have access to that and such. I remember in the VA, they were like, wait, what is that? And I was like, I remember learning that in training. I'm sure I'm not making that up, right? So in terms of advocating for that, there's specific central labs that we could be asking to send to. I mean, obviously we do a lot of that stuff here, but for people that may not have access to that, and, is there specific places or what should they be asking or talking about for that?
I mean, it depends on the geography. Most states in Australia will have at least one laboratory that has these specialised tests. But asking at your nearest sort of tertiary high level hospital whether they have the capacity. And it also will depend on the sort of geography of the situation. Obviously, with a higher mesothelioma rate in Australia, we're all over it. BAP can be used for other things, including melanomas. So there might be cross uses for those sorts of things. And MTAP being something for CDKN2A is starting to be used in things like CNS uses. So if you've got a big tertiary centre that uses neurosurgery or soft tissue nearby, or even skin specialty, they might have these stains on site.
Awesome. And then I will ask you one last question and set you free. But in terms of, we're talking about kind of, getting in touch with pathologists and making friends and such. But in terms of, expediting, how fast or kind of what's a reasonable time frame we can expect some of these things? We obviously shouldn't be calling you and trying to expedite everything for everybody, but we do, especially in Australia, especially in WA, we have a lot of rural patients, country patients, or patients that are just quite ill and we need to try to get an answer sooner rather than later. But can you just maybe comment a little bit about on that?
Yeah. So again, it will depend on your pathology service and the ability of cytopathologists. But usually, essentially, if you do a rapid on-site assessment, if you've got the capacity to call someone for that, then someone can come up if you're doing sort of a CT or an ultrasound biopsy and give you an on-the-spot imprint or FNA interpretation, and you should be able to get within minutes an understanding. If you're doing a pleural fluid tap on someone, again, we do it here. I cannot promise that all other laboratories will be, but if you talk to your pathologist, they might be. It takes about 20 minutes to process a fluid if you do it sort of only occasionally and for special things. So we, within half an hour, if you deliver us a fluid by hand, we can get it processed within 20 minutes and spend 5 minutes interpreting it and give you a call. On the ordinary, that half-hour processing will take place, but it'll be a position in a queue because we get, in our laboratory, dozens of cases a day. So it'll take maybe a day for all the processing and the laboratory push through to happen, another day for the scientist to screen it, and then it'll land with the pathologist. So at a minimum, probably 2 days if it goes through normal systems, and then it could extend out to 4 or 5 or even 6 or 7 if you have to do immunohistochemistry. So if I look at a case and I see that there's a singly dispersed mesothelial population that arrived 2 days ago, I'm going to have to request immunohistochemistry. That's going to take at least 24 hours. And when it arrives, then I'll have a look. And then, so by then you're at sort of 3 business days. But putting urgent on actual urgent cases, calling your pathologist about cases that are really critical, they can jump them to the front of the queue for you.
Awesome. Thank you so much, Celia, again for your time and your expertise. Always appreciate learning from you. And I'm sure our colleagues logging in have learned quite a bit today as well. And hopefully they'll be calling their pathologist a bit more with urgency, or at least with some information that helps them get to the bottom line, with what we're trying to figure out for the patient. So, and again, everybody online, thank you again for joining us. We will have this uploaded shortly, so you can always watch it and share. Thank you for joining us, and join us next month. We'll be having some more exciting speakers and we'll go from there. Thank you.
Thanks, everyone.